Hello everyone, my name is Bob Lampton. I am a nurse. I have been a nurse for 10 years. Most of that time I've been in what is called a progressive care unit nurse. It's also sometimes called the telemetry unit. I'm making this video as part of an education project I'm doing for Sihanouk Hospital in Phnom Penh, Cambodia. This is just kind of an educational tool I'm using for this nonprofit organization to help educate the nurses on basic EKG interpretation. So you'll probably notice I use several pictures in these slides. If they are copyrighted, that's noted on the picture. You probably also note that I didn't produce any of these. I just borrowed what I found looked like good strips to help teach the students. There I will include some links under the video of where to get them, as well as some good resources for helping practice them. So first we're going to start out with some basic heart anatomy. As you know, the heart is made up of 4 chambers. There are 2 atria on the top of the heart and 2 ventricles on the bottom of the heart. The atria and ventricles are also divided into right and left. Blood returns to the heart from the body into the right atria, travels through the right atria into the right ventricle, where it's then pumped into the pulmonary circulation. The oxygenated blood is returned to the left atria and then enters the left ventricle and then is pumped out into the general body circulation from there. So now we'll take a look at some more specific anatomy that EKGs specifically deal with. EKGs do not tell us how well the heart is pumping. It specifically tells us how well the electrical activity is occurring inside of the heart. Whether or not the heart actually contracted is not something we can determine from an EKG. That requires other methods. So the sinoatrial node, or more commonly known as the sinus node, is where the normal overriding pacemaker of the heart. It normally runs at a rate of about 60 to 100 beats a minute. It usually initiates the impulse. It fires, that then travels down through the atria down to what's labeled number 2, or the atrioventricular node, or the AV node. It's usually then held in the AV node for a short time to allow the ventricles to completely fill. The impulse is then transmitted down the AV bundle and is branched off into the left and right bundle branches, which was number 3 on the picture. It is then transmitted into the nervous tissue directly innervating the muscle, which is number 4, also known as the Purkinje fibers. Now, each of these, the sinus node, the AV node, the Purkinje fibers, and even the atria themselves can create their own impulses at times. So each of these EKGs is printed out on a kind of grid paper. These little boxes going from left to right along the horizontal axis tells us how long it's taking for this thing to travel through the heart. Now, each of these small boxes measures 1 millimeter square, and it equals 0.04 seconds. Now, these are grouped into boxes of 5, which makes one big box, which is equal to about 0.2 seconds. And 25 of the small boxes, or 5 of the big boxes, equal 1 second in real time. And we'll use these boxes as references to measure out different portions of the EKG as we're going along. So it's important to remember what these are. And if you happen to have it printed out on a piece of paper that doesn't have the grid on it, and you do have a ruler, just remember that one of these small boxes equals 1 millimeter. So this is what a normal sinus beat looks like. It begins with the initial bump, which is called the P wave, then travels through until it generates what is called the QRS complex. It's a large spike. So you can see the labels. The Q is the first downward spike, the R is the first upward spike, and the S is the return to the baseline. Then the last wave is called the T wave. So the P wave signifies that the sinus node has generated the impulse, and from the beginning of the P wave to the beginning of the QRS complex is known as the PR interval. It can be kind of confusing as to why this isn't called a PQ interval, but it's because most people don't have Q waves. They just have an R wave. So the time it takes from the beginning of the P wave to the beginning of the QRS is normally 0.12 seconds to 0.2 seconds. That's 3 to 5 small boxes in length. The time it takes to travel from the AV node down into the ventricles themselves is what tells us the width of the QRS complex. It's normally less than 0.1 seconds. The time it takes from the Q wave until the end of the T wave can be important when determining a 12-lead EKG, but we're not going to go into that in this lesson. What we do need to look at, though, is the area between the end of the S wave and the beginning of the T wave. It's known as the ST segment. It's a very important segment for diagnosing heart attacks or MIs, and it's very important to know how to identify it, as it gives us many other clues when identifying some of these rhythms. So our T wave signifies that the ventricles are recovering and that they're ready to begin the next depolarization for the next heartbeat, hopefully. So when we're interpreting an EKG rhythm, I have some rules or steps that you go through to evaluate the rhythm. The first rule is look at your patient. The rhythms we're going to see can be created by interference from movement or electronics. So if your monitor says that this person's heart isn't beating, but they are awake and talking to you, then you need to trust your instincts and your vision telling you that this patient is okay and not a possibly disconnected wire. So once we have ascertained that the patient, the rhythm does fit the patient, now we can sit down and actually evaluate what is the rate, and this is very simple. There is a complex way of calculating this, but the simplest way is to take a 6-second strip and just count the number of QRS complexes. That's and then you just add a 0 to that, and that gives you an approximate beats per minute. So if there's 6 QRSs, it's 60 beats a minute. We check to see if it's regular. From the top of the QRS complex to QRS complex, there's a certain distance, and if that distance remains constant from beat to beat, we say it's regular. If the distance changes by more than 0.05 seconds from beat to beat, it is irregular. Now we look for P waves, see if there was a P wave for all the QRS generated, and that we don't have any QRSs out there by themselves, and we don't have any P waves out there by themselves. If you notice any of that, it tells you something. And then we look at how the P waves actually look themselves. If they are all the same shape, then that tells us they're all coming from the same place. If they have different shapes, then it's a sign that it's coming from different places within the heart. And then we measure out what the PR length is and the QRS length is. And depending on the lengths of those, it gives us an idea of what we can call it. Now, there are a lot of rhythms. There's somewhere between 30 and 40 of them that we will identify in this lesson. And there are a lot of rules to remember. So don't expect you're going to remember them all right away. Give yourself plenty of time to remember these. It will take you days to weeks to remember them, and it will take you months in actual practice to actually feel comfortable identifying them on the monitor without having to print it out and do all the full measurements. So give yourself time and excuse yourself when you make mistakes on them. That's expected and an important part of the learning process. This is what is known as normal sinus rhythm. It's called normal because this is a sign that the electrical activity within the heart is functioning normally. It has a rate of 60 to 100 beats per minute. It is regular. There is a P wave for every QRS and a QRS for every P, and the P waves all look the same. Our length of PR interval is 0.12 to 0.20 seconds, and our QRS is less than 0.1 seconds. When we look at this specific rhythm strip we have, this is a 6-second strip. So we count the number of QRS complexes. There are 8 of them, so that gives us 80 beats per minute. When we measure from R to R interval, we are regular. They are all the same distance apart. There are P waves with every QRS and QRSs with every P. When we measure our PR and QRS intervals, they fall within the defined limits. When we have all of those, it tells us this is a normal sinus rhythm. Now, that doesn't tell us the heart is normal, it just tells us the electrical activity of the heart is working normally. This person could have serious problems going on with their heart and still have a normal sinus rhythm. Again, you want to look at your patient first. This is just one more piece of the picture, not the entire thing. The next rhythm we have here is called sinus bradycardia. The sinus tells us that it is still coming from the sinus node. The bradycardia, brady means slow in Latin. So this is a sinus heart rate that has a slow rate. So that tells us that the rate is less than a normal sinus rhythm, so less than 60 beats a minute, but it is still regular. There's still a P wave for every QRS and QRS for every P, and all the P waves still look the same, and the PR interval is still the same of 0.12 to 0.20, and a QRS is still narrow. Now, when we look at this specific strip, we count the QRS complexes, that gives us a rate of 40 beats per minute. R to R is regular for all the beats. There's still a P wave for every QRS and QRS for every P, and all the P's on this one look the same. And if you do measure out the PR and the QRS for this particular strip, they do fall within the defined limits. This may be normal for your patient. If your patient happens to have a very strong heart, such as they are a long-distance runner or ride their bicycle a lot, their heart may be strong and just doesn't need to beat as often as a regular person's heart. Again, go back to the first rule. Look at your patient. If they seem fine with it, then there's no problem. If they are diaphoretic, they are sweating a lot, they are weak, pale, dizzy, that's a sign that they're not getting enough blood flow to their brain, and you need to address it. But again, if they feel fine with a heart rate like this, then there's no issue. Now, the opposite of sinus bradycardia is sinus tachycardia. Sinus, again, is just coming from the sinus node. Tachy is Latin for fast, so this is a fast heart rate still coming from the sinus node. So just the opposite, it has a rate over 100 beats per minute. It is still regular, but we can still distinguish a consistent P wave with every QRS. If the PR is appropriate, you can measure it out and get the appropriate reading as well as the QRS. If you cannot see a P wave in there, then it's defined as something else. And the way we're defining it's a P wave is that there is that wave before the QRS and it is consistent beat to beat. When you measure this one out, it is about 12 beats, so that's about 120 beats per minute. It's regular from R to R. You see all the P waves are consistent, they are in there, and you are able to measure out a PR interval and a QRS, and they all fall within defined limits. This is, again, can be a normal heart rate if your patient is active, if they're actually up walking around. This is a normal response to activity. If your patient is laying in bed relaxing and they have this heart rate, that's usually more likely a sign of some type of volume depletion, such as they're dehydrated or have lost blood. And this is just one more component of your total picture that they have a fast heart rate from some other cause. Again, depending on how your patient is doing, tells you whether this is a serious rhythm or not. This type of rhythm is similar to the first three that we've looked at. The only difference being that it happens to be irregular. We can define it as a sinus rhythm because we do have P waves with all the QRSs and they do all look the same. But when we measure from R to R, it happens to be irregular. This particular one is a rate of 60 beats a minute. It's irregular. The P waves are there and they all look the same, and the PR interval is still correct. The only problem is that since it's not regular, it tells us it's not a normal sinus rhythm. It's a sinus arrhythmia. So you can further define this. This one is just a sinus arrhythmia. If it happens to be over 100 beats a minute, it would be a fast sinus arrhythmia. Or if it happens to be under 60, it would be a slow sinus arrhythmia. Now, the irregularity is usually related to their breath. When they breathe in, the irregularity changes. And this can be a sign, nothing serious. It's often common in younger adults. Again, if the patient overall is looking good, there isn't much of a concern here. This is something known as a sinus pause. As you can see beforehand, there was a sinus beat, so we know this person is having a sinus rhythm of some sort going on. And afterwards, there happens to be a sinus beat. The sinus node just seemed to have taken a break for about 3 seconds in the middle there. So you know it's a sinus pause because you have sinus beats leading into it. The recovery from this, such as when the heart starts beating again, can be a different type of beat. But as you can see in this case, it has to be a normal sinus beat begins right afterwards. You measure out how long it is between pauses and record that. Anytime they're having a pause of a second or more, that's usually something very serious going on. And it's something you need to talk to the doctor about and get the underlying issue addressed. This is usually a sign that something very serious is happening in the patient, and if it's not found, can be very serious, if not fatal. Now we are getting into the atrial rhythms. Just as you might remember from the anatomy slide, the sinus node happens to be a part of the atria. There is other neurological tissue in the atria that can also generate beats. This one we are looking at right now is called atrial fibrillation, or AFib for short. It is the most common arrhythmia, and it is irregularly irregular. That is the kind of main defining characteristic of it, is there is no regularity from beat to beat. You cannot find any kind of rhythm, and if you happen to come across any kind of regularity in it, it's accidental. There's no good P wave to go on. You can see a lot of underlying chaos kind of in between the beats. There's no steady isoelectric line to go by. There's nothing flat to give us a bass to work from. It's all just a bunch of chaos in between the beats. So when we measure this one out, we count the beats. There are 9 of them. This still has a narrow QRS. And just like with the sinus arrhythmia, we want to define this further as whether it is a fast AFib having a rate over 100, a slow AFib with a rate under 60, or a rate controlled with a rate between 60 and 100. Now, as I said, this is the most common arrhythmia because it is a survivable arrhythmia as long as the person has a controlled heart rate. People will usually present to the emergency room with the onset of this because their heart is going so fast. The atria are sending out a whole bunch of impulses, and they are all getting through and causing a very rapid rate. And it requires us to give them medication to try and slow their heart down. Now, if we give them too much medication, that could cause their heart rate to go lower than 60 beats a minute. In that case, we would call it a slow AFib, in which case we need to notify the doctor that this person is having a low heart rate so that they can cut back on the medication they're prescribing for rate control. Again, this is a very common dysrhythmia, and people can live with it for decades as long as they have good rate control and some type of anticoagulation or blood thinner on board. This has other issues associated with it, but I will not get into those in this particular presentation. Now, a similar rhythm to AFib is something called atrial flutter or A-flutter. It is similar because it's a result of multiple impulses coming from the atria and can also result in an irregular rhythm and can be very fast. And there's times when you're looking at something you may not be sure whether it's atrial flutter or atrial fib. I don't want you to focus so much on differentiating between atrial flutter and atrial fib. The main thing you need to focus on is the rate controlled. If it's irregular and you're not sure if the waves in between are flutter waves or fib waves, then as long as their heart rate's controlled, that's a question for a cardiologist and an outpatient doctor. So in the hospital, they're most likely going to come in with a fast rate, and our focus is going to be on controlling that rate so their ventricles have an adequate amount of time to fill. So this particular rhythm may be regular or irregular, and you'll notice in between the QRS complexes that there are 3 distinct waves. These are called flutter waves. Those are signs of atrial contractions happening. If you count them out, this one, this there are 3 flutter waves to every ventricular contraction for this patient. If it is regular like this, you need to count out how many flutter waves there are and say this is a 3-to-1 atrial flutter. That means there's 3 flutter waves to every QRS. And just like AFib, it can be fast, slow, or rate controlled. The biggest issue, again, when they come in is getting their rate under control and getting most likely some type of anticoagulation on board. Now we're getting into a more complex form of atrial rhythm. This is what is known as a wandering atrial pacemaker, sometimes called a WAP. It happens to have a rate of less than 100. Now, it can be regular, but it can also be irregular. But when we look at our P waves, there are usually P waves for every QRS, but they happen to be all different shapes. Now, if we see at least 3 different shapes, we can say it's coming from multiple pacemakers within the atria. The PR can differ depending on the shape of the P wave, but we do have P waves there. They just happen to all be shaped differently. This still has narrow QRSs, so we know it's the fact that it's coming from another pacemaker is determined by the differing shapes. If it's coming from the same pacemaker, the P waves beforehand will all be the same shape. If it's coming from a different one, it will have a different shape. Now, as you'll remember from the last slide, it was had a definition of a rate less than 100. So if it happens to have a rate of more than 100, then it has a different name. It's called multifocal atrial tachycardia. Multifocal means it's coming from multiple different places in the atria, and it is a fast heart rate. Now, I suppose you could call it a wandering atrial pacemaker tachycardia, but the technical name for it is multifocal atrial tachycardia. Just like the last one, we still need the 3 different P waves. We still need a narrow QRS, and again, it can be regular or irregular. And there are a lot of times when you may not be sure because of the irregularity whether it's AFib or it's a multifocal atrial tachycardia. And I think that's a question that an echo can answer more than anything else if you're not sure. Again, focus more on, as we're looking at a hospital setting here, on the acute needs of this patient, which are rate control. So if when you're checking for regularity in a rhythm, and you notice that overall it's mostly regular, but there happen to be a couple of irregular beats, then you take the next step and look at the P waves. Now, when we look at the P waves of this strip, you can see overall most of them look the same, except for 2. There's 2 where the P wave is significantly different. And the fact that this is significantly different tells us that it's coming from places other than the other beats. So if we have a P wave for those irregular beats, but they happen to look different, that tells us it's coming from another part of the atria. If it doesn't have a P wave for that irregular beat, it is not coming from the atria. Now, if it can happen with pretty regularity, such as if it happens every other beat, then this is called atrial bigeminy. And if it occurs every 3rd beat, it's called atrial trigeminy. Remember, the bi in bigeminy means 2, like a bicycle, and the tri in trigeminy, it means 3, like a tricycle, has 3 wheels. Now, Wolf Parkinson-White syndrome is a type of conduction abnormality in the heart. It is caused by an extra pathway between the SA node and the ventricles. It results in an odd-shaped QRS that is usually wide, and the PR interval as a result of this is usually narrow. But again, the PR interval can be normal, and the QRS can be narrow. The main thing you're looking for is, instead of a drastic upward R wave, it has a more slope to it. This is called a delta wave. This can result in a fast heart rate, but it is a very rare syndrome and usually is completely harmless in people. This next rhythm is called supraventricular tachycardia. Supra means above, and ventricular is the ventricles, so this is a tachycardia that is originating above the ventricles. The main characteristic of this is that the QRS is less than 0.1. That is how we differentiate it from ventricular tachycardia. If it had a wide QRS, it would be ventricular tachycardia. The other main characteristic of this is that the QRS complexes are so close together that the T waves obscure any possible P waves that might be there. We don't know where above the ventricles is coming from. It could be coming from the AV node, the atria, or even the sinus node. And the issue is we won't know until we get it slowed down enough to see what is happening between the T wave and the next QRS complex. The focus of this management-wise is to try and slow the heart down as quickly as possible. This can be done with vagal maneuvers or other things such as medications, but again, this strip you're looking at right now is over 200 beats a minute, and no one's heart is going to hold out for that long doing this. It's going to have some type of heart damage if this continues unfixed. The next set of rhythms we are getting into are known as junctional rhythms. They are called junctional because they originate at the AV junction. The main characteristic of this is that there is no distinct P wave present, or if it is, it's partially buried inside the QRS. It is still very regular, and as you look at this strip here, you might notice that the baseline looks kind of like an AFib, but because it is so regular, we know that is how we know it is coming from the AV node rather than the atria. If it was irregular, we could call this a slow AFib. The normal rate of the AV node is 40 to 60 beats a minute, and it produces narrow QRSs. Again, you want to make sure that QRS is narrow, or it can be coming from somewhere other than the AV junction. Now, as the AV node's normal rate is 40 to 60, it can run faster than that, but if it's not yet over 100 beats a minute, which is tachycardia, we call it an accelerated junctional rhythm. So this is going faster than the normal rate, but is not yet considered tachycardia. Again, that's a rate of 60 to 100 beats a minute. It remains very regular, and there's still no P waves in here, and we have narrow QRSs. Now, this person may be fine with this rhythm if they're maintaining circulation. Again, there needs to be some kind of investigation by the physician as to why the AV node is taking over and the SA node is not functioning properly. Once the rate gets over 100, it now becomes junctional tachycardia. As the normal definition of tachycardia is anything over 100 beats a minute, but this one happens to not have any P waves, and it's not irregular, So we call it junctional because the absence of the P waves, the narrow QRSs, and it's regular. The regularity is what defines a pacemaker, is it's regular. If it's not regular, it's coming from somewhere other than the pacemaker. Just as we had the PACs before, now we can have a PJC. That's a premature junctional complex or contraction, as it's sometimes called. Now, as you look at this strip here, you'll notice that it's mostly regular except for one irregular beat. It's the fifth beat in this strip. Now, when you look at the P waves for the first rhythms that are regular, you notice that they all look the same, but we have this single irregular beat that doesn't have a P wave. And because there's no P wave, that's how we define it as a premature junctional complex. Again, it has a narrow QRS, or it could be another type of premature complex. The QRS being less than 0.1. And just like with atrial bigeminy and trigeminy, we can have junctional bigeminy and trigeminy. It's, again, every other beat, it would be called junctional bigeminy. Every third beat, it would be junctional trigeminy. You usually want to identify the underlying rhythm first. So when we look at this one, it would be a normal sinus rhythm, as it's 60 beats a minute, but it has a PJC. So we would call this a normal sinus rhythm with a PJC. Now, as I said, the PAC and the PJC need to have narrow complexes. If it happens to have a wide complex, then it becomes a PVC, a premature ventricular complex or contraction. This is originating from an otherwise narrow QRS rhythm, such as a sinus, atrial, or junctional rhythm. And when you look at this strip, you notice that every other beat looks significantly different than the underlying ones. Now we look at the P wave. So we have the narrow QRSs all have P waves, but the wide QRSs do not. And you can tell from looking at the QRS complexes from the narrow ones to the wide ones that the wide ones are significantly different. Now, these occur, anything that arises in the ventricles takes longer to generate a pulse. So that is how we know that it's coming from the ventricles. It has wide, it has this funky look to it that you can tell it is different from the other ones. If these occur in pairs, it's called a couplet. If it occurs 3 or more in a row, and it happens to be over 100 beats a minute, then we would call it ventricular tachycardia. If this particular rhythm we have here is called a ventricular bigeminy. Again, if it was every third beat, it would be ventricular trigeminy. There's usually a serious sign. Having a PVC every now and then is fairly benign. It can be a caused by stress, too much caffeine, certain medications. If it is occurring with this regularity, such as every other beat, there is something more serious going on that needs to be addressed. If it's occurring regularly, it can be a sign of electrolyte imbalances or myocardial ischemia or bad blood flow to the heart. We also want to define the shape of it. Now you'll notice in this strip that all 3 of these PVCs look essentially the same. And because they look the same, they're probably all coming from the same part of the ventricles. So we would call this unifocal PVCs. If they were differing shapes, we would call it multifocal, because the differing shapes would tell us that it was coming from different parts of the ventricles. As I explained in the anatomy slide, the Purkinje fibers in the ventricles can create their own pacemaker. It happens to be the slowest pacemaker and results in these wide QRS complexes. The way we define this is one, it is slow. This one we're looking at right now is 30 beats a minute. It has wide QRSs. When we measure this one out, it's about 0.2 seconds rather than the 0.1 we are looking for. There are no P waves, and it is still regular. That is how we would differentiate it from the junctional rhythm. Well, it is still regular, but it has the wide QRS complexes. This person is probably not going to be tolerating this for very long. If they happen to feel fine, it's probably not going to last long, and they probably have some blood pressure issues with this. The main treatment for this would be some type of pacemaker, as well as finding the underlying cause of why they're in a idioventricular rhythm rather than a regular one. Again, this is called an idioventricular rhythm, but if you just want to call it a ventricular rhythm, that is okay also. Just like we had the accelerated junctional rhythm, we could have an accelerated idioventricular rhythm. Now, I made a mistake on this slide here. It should say 60 to 100. So if you remember, our normal idioventricular rhythm was 20 to 40 beats a minute. Still regular, no P waves, and a wide QRS. But it's not over 100 yet, so we're not going to call it tachycardia. It's called accelerated because it's faster than normal for the ventricles, but not yet too fast. And this person may tolerate this fairly well. They may not notice it at first. This is usually caused by something fairly serious, so once you identify the underlying problem, when the doctor identifies the underlying problem, then you can go forward from there. Now, once we get over 100 beats a minute, it is called ventricular tachycardia, or VTAC for short. It has a rate of over 100 beats a minute. It can be regular or irregular. There's no P waves, and you can't really make out any T waves in this either because it's being obscured by the next QRS complex. And the QRS complexes are wide, telling you it's coming from the ventricles. That's how we differentiate this from the supraventricular tachycardia, is we have the wide QRS. If they happen to be all the same shape, we could call it monomorphic tachycardia. They can come in varying shapes, and then we would call it a polymorphic ventricular tachycardia. This is a fatal rhythm and needs immediate intervention. This person needs immediate cardioversion, which your doctor will hopefully prescribe immediately and begin. This person will likely be awake at first when this happens, but they will lose consciousness eventually. And if you are going to shock them, it's a good idea to let them at least pass out first before you shock them. Now, as I said, there can be a VTAC that is called polymorphic. And when you look at this strip, you'll notice that the QRS complexes look significantly different from beat to beat. This is called torsade des points, which is French for the twisting of points. It means that a kind of a regular rhythm of changing of the morphology of the QRS complexes. You'll probably notice it has kind of a pattern where it looks kind of like a wave, where it's going from narrow to bigger, back to narrow, back to bigger. It has this kind of center point that it's changing around. The reason it's important to notice this is that when it's occurring, it's almost always caused by a low magnesium level. You can shock this person out of this, but if you haven't corrected the magnesium level, they will just return right to it. So it's something that you will find in the advanced cardiac life support algorithm that when you have this, the first treatment is administering IV magnesium. Now, a more serious rhythm is called ventricular fibrillation. There's no discernible P wave or QRS in here. It's just a bunch of erratic, chaotic electrical activity. At times, this can look very similar to polymorphic VTach. The important part to remember is, one, look at your patient. If they're in polymorphic VTach, they might still have consciousness for a little while, whereas with ventricular fibrillation, or VFib, they will not. This is simply nothing organized is happening in the heart. It's just kind of quivering, shaking around, not really pumping any blood. This needs immediate CPR and defibrillation. If you have an AED, hopefully it would identify this and shock this person right away. The longer you wait to shock them or to begin CPR, the lower their survival rate is. Every minute that they are not defibrillated, their survival chances go down significantly. Now, this is another fatal rhythm. It's called asystole, sometimes called flatlining. There is absolutely no QRS complexes here. And as you can see in this strip, this particular heart has regular P waves. So this patient may be having atrial contractions, but without the QRS complexes, they are not having any ventricular contractions. So we define the asystole by what the ventricles are doing. As you might remember from the AFib, the atria are not really contracting, but the ventricles are still contracting, so that person can survive with that for decades. This person will not survive more than a few minutes without some kind of intervention. Only hope for this person is beginning CPR immediately and hoping their heart wakes back up at some point. This next rhythm is known as agonal rhythm. It's this sign of the dying neurological system of the heart. The heart, it's even a little more serious than the asystole, I think, because once the damage to the neurological system of the heart has occurred, there's essentially no hope. A person could lose half the muscle in their heart and still have some blood pumping, but once the nervous system is gone, there's nothing to stimulate the heart to continue to go. So it's very slow, it's very wide, and it's also irregular. When you measure out the QRS complexes on this strip, it's about 0.4 seconds. And if you look for regularity, there should be another beat at the beginning of the strip and another one at the end of the strip. So that tells us this is an irregular rhythm. No P waves, and again, this is usually the last rhythm you see right before someone's heart is gone. Now we are getting into the block rhythms. These are conduction delay problems in the heart. This one we're starting with is called a bundle branch block. If you remember in the anatomy of the heart, under the AV node, it is sent down through the AV bundle, which is then branches off into a left and right bundle. Now, if there's some type of myocardial problem in there that causes some scar tissue to form, it can slow down the pulses through these bundles, and that leads to a wide QRS. Now, on a 12-lead EKG, you can further differentiate this into either the left or the right bundle, and that is important when you're trying to diagnose an myocardial infarction or a heart attack. The problem is you cannot do that on a single strip. It needs to be done on a 12-lead EKG. And you'll probably say that this makes it a little more difficult to differentiate from a ventricular rhythm, and that can be a problem. So the way we're going to differentiate it from a ventricular rhythm is, one, this rhythm has a P wave in it, and it is still regular. It can come in an AFib, but where there isn't a very definite P wave, but if it is a P wave or it's irregular, then you would call it a bundle branch block. If it happened to be wide and regular without a P wave, that would how you would identify some type of idioventricular rhythm. Now these next rhythms are known as the AV block rhythms. These are a result of a delayed exchange between the atria and the ventricles. This can either be in the atrial conduction pathways coming from the SA to the AV node, or it can also be within the AV node itself. Either way, there's some kind of problem with the conduction between the atria and the ventricles. This first one is called first degree AV block. It's defined by a long PR interval. Normal, as you remember, is 0.12 to 0.20 seconds. This one is longer, more than 0.2. Its P waves are still present, and they still occur regularly. Well, I suppose if it was an atrial sinus arrhythmia as well, it could be irregular. But we do have a P wave, and when we measure the PR interval for each complex, we'll notice that it is essentially the same for each one. This particular one we're looking at here happens to be a 0.4 second PR interval, which is twice what it should be. This is almost always a sign of a heart attack, past or present. If this person has not had this problem before, it gives you one more piece of the puzzle telling you this person might be having a heart attack. If it's chronic, this is a survivable rhythm. People can walk around with this for several years and not be bothered by it, as long as it doesn't progress any further. Our next rhythm is called second degree AV block type 1, also known as Winky-Bach, or second degree AV block Mobitz 1 is another one. The pattern of this is, you'll notice at the first beat we have a normal PR interval, but the next beat after that it's long, and the next beat even longer still, and the next beat even longer still, until we have a P wave without any QRS whatsoever. This is the pattern of Winky-Bach, is a progressively longer PR interval with each beat until you drop a QRS. This person may be symptomatic with this. This is another sign of a heart attack, and usual treatment for this is implantation of a pacemaker of some sort. Second degree type 2 AV block, or Mobitz type 2, also involves some solitary P waves, and when the PR interval is present, it remains constant from beat to beat. There just happens to be several P waves without a QRS complex associated with them. As you remember, type 1, it had the pattern of the progressively longer PR interval until it drops a beat. That is how we differentiate this from type 2, which has the same PR interval where present, it just happens to be dropping QRS complexes. This person is probably symptomatic with a rate of 40 beats per minute, and again, this is usually a sign of an MI of some sort and requires a pacemaker usually. Now, the most severe type of heart block, known as third degree AV block, also called complete heart block, it means that there's no communication between the atria and the ventricles whatsoever. They are each doing their own thing, they just aren't talking to each other. Now, if you measure the P to P interval, it is regular, and if you measure the R to R interval, it is also regular. But when we look for something in the PR interval, there is no consistency or pattern to it whatsoever. Remember, in second degree type 1, there was a pattern of change of the lengthening PR interval. In second degree type 2, the PR interval stayed the same. But this one, there's no pattern whatsoever. And if you look at the first QRS complex, there's actually a P wave buried in the T wave. Now, this, again, is a sign, it's the most serious sign because the ventricles are on their own, and they usually aren't pumping fast enough to get enough blood to the body. They happen to have the wide QRSs you might expect from a ventricular rhythm, whereas all the other types had narrow QRSs because the beats were still getting through. But again, this is, they call it complete heart block because there's no communication between the atria and the ventricles whatsoever. Now we're including some pacemaker rhythms. These are artificial pacemakers implanted in the body. They produce small electrical spikes. If you look at this particular rhythm, you'll notice that single spike before each P wave. And if you have a spike before a P wave that then creates a narrow QRS, then you have a single chamber atrial pacemaker. It is just in the atria generating a pulse, and then which then travels down through the system, creates a normal normal QRS beat. This leads to because it's results in an atrial contraction as well, increases the cardiac output a little over what would be our next rhythm, which is a ventricular pacemaker. Now, the ventricular pacemaker is, you won't see any P waves, and it produces wide QRSs. You'll notice the little pacer spike between each of these wide QRSs, which all happen to be regular. Usually these pacemakers work at a minimum of 60 beats a minute to maintain adequate cardiac output. Sometimes they have multiple leads implanted in the heart, and this can create atrial as well as ventricular contractions. The biggest characteristics of this is that we have 2 pacer spikes per beat. The first pacer spike, as you'll notice, creates a P wave, and the second pacer spike creates a wide QRS. So this, again, we're having the atrial and the ventricular contraction, so this is helping produce more cardiac output than the normal ventricular pacemaker would. Now, pacemakers can have problems when they're working. Just like any other machine, they can have errors. And one of these is where the pacemaker lead is not generating QRS complexes. It's usually a sign that the lead is no longer connected where it should be. It's just producing electrical impulses away from the heart itself. And the main characteristic of this is we have these pacer spikes out by themselves. As you'll notice, there are some pacemakers spikes creating QRSs, but there are 3 in this one that are out by themselves. And when you measure from wave pacer spike to pacer spike, you'll notice they are still regular. So it's trying to work at a normal rhythm, and the pacemaker overall is working well. It just isn't connected in the right places. Now, this next problem is called failure to sense. Normally, the pacemaker senses when there has been a heartbeat and when there has not been. And if there has not been, it creates a pacemaker spike. Now, when you look at this, you'll notice there's a long stretch where there are no pacemaker spikes and no QRSs. You'll notice there's one pacer spike on the first QRS, and then the heart creates some of its own, and then it stops, and there's no pacemaker spike to occur there. You'll probably also notice that after the pacemaker restarted, that it's doing an AV sequential, as there's 2 pacer spikes for each beat. This is usually a sign of a damaged internal computer of some sort, and only treatment for it is replacing the pacemaker. Main sources I got these strips from are the websites I've listed here, ekg.academy and practicalclinicalskills.com, which is where EKG Academy got most of them, as well as Float Nurse Mike's blog. These are wonderful sites with good information on them. ekg.academy also has lots of practice strips, and I encourage you to go there to practice your skills.